Good morning everyone from Department of Neurosurgery, King Edward Medical University, and today we are here to discuss the surgical management of pituitary lesions, and by pituitary lesions we mean the pituitary adenomas in this context. So let's proceed. The pituitary adenomas, they are broadly classified into two different types. The first type that produce the hormones, or they oversecrete the hormones, are called as functional, and the second types which do not oversecrete the hormones are non-functional, or also known as non-secretory type of pituitary adenomas. So these secreting tumors tend to present earlier as a result of symptoms caused by the physiological effects of excess hormone that they secrete. So usually the secreting type of pituitary adenomas, they present earlier in life, whereas the non-secreting type, they only present to your clinic once they produce symptoms because of mass effect. Once they grow large in size and they compress the nearby neurological structures, then they will create a similar symptom, and then the patient will present to your ward. So almost 65% of the adenomas, they secrete active hormones, out of which 48% are prolactin. So out of all the secretory tumors, prolactinomas are the ones with highest percentage, and since they secrete large amount of prolactin hormone, they cause amenorrhea, galactorrhea syndrome in females, whereas in males they may create impotence. The pituitary adenomas that secrete more growth hormones, in adults they cause acromegaly, whereas in prepubertal children they produce pituitary gigantism. The tumors that secrete more corticotrophin, or ACTH, Cushing's disease could be the end result, and if the tumor hypersecretes thyrotropin, or TSH, this may lead to secondary hyperthyroidism. LH and FSH are not that much important symptomatically. So if the tumor is large in size, especially with the non-secretory type of tumors, then these mass may compress the pituitary gland, resulting in underproduction of hormones. So all these hormones will go low. The first one to be affected is growth hormone, second LH, third FSH, TSH, ACTH, and then prolactin. You can also remember the mnemonic. Go look for the pituitary adenoma, please. The pituitary adenoma, once it enlarges in size, it might compress the surrounding neurological structures. This is most commonly seen with non-functioning tumors, whereas among the secretory tumors, prolactinoma also tends to be very large and create mass effect. Once it compresses the optic chiasm, remember it produces bitemporal hemianopsia. So remember this line. Also, if it goes up and compresses the third ventricle, it may create obstructive hydrocephalus. Okay. Similarly, on the lateral sides, if it compresses the cavernous sinus, okay, it might create pressure on the contents of the cavernous sinus, like cranial nerves number 3, 4, V1, V2, and 6, and this may lead to ptosis, facial pain, and diplopia. Also, the occlusion of cavernous sinus itself could give rise to proptosis among the patients, and also chemosis. So the carotid arteries that are lying on the other side, if they are encased, that might create slight narrowing only of the ICA on the affected side, but pituitary adenomas, they will never occlude the ICA. In cases of prolactinomas, the patients present with CSF rhinorrhea, and in these patients, this is a very small group of patients who present with CSF rhinorrhea, and in these patients, once medical management has been started, the tumor starts to shrink itself and the amount of rhinorrhea increases. This is another complication that we have seen. The macroadenomas, it may produce headache. How? Because of the increased intracellular pressure. In any pituitary adenoma cases, history and examination, these two are the most important exams that you will do by history and examination alone, you can already diagnose 80-85% of the cases. Third one would be ophthalmological examination, in which you will look for visual acuity, visual field by confrontational test, and also you will ask for visual perimetry with the help of ophthalmological department, because you need to document the visual field loss preoperatively and postoperatively as well. Fourth thing is hormonal profiles. You'll ask for all the hormones that will be secreted by the pituitary gland, like prolactin, insulin like growth factor 1 instead of growth hormone, because this is more sensitive, cortisol, TSH, free or total T4, LH, FSH, and BSL. For radiological investigations, pituitary MRI is the gold standard for the investigation. How you will ask for pituitary MRI protocol? You will ask for MRI T1, T2, T1 with contrast, and you will get the MRI after 30 minutes of contrast, so that the pituitary adenoma will take the contrast after this amount of time. You can also ask for CT scan. This is for to know about the bony abnormalities if you are going for surgery. So prolactinoma is the only secretory adenoma which is treated by medical management initially, and if it fails, then only you will go for surgical management. So pituitary adenomas, on the basis of their sizes, are divided into these groups. It's called microadenoma if it's less than 1 centimeter, macroadenoma if it's more than 1 centimeter, and giant macroadenoma if it is more than 4 centimeters. So this is the MRI. The first MRI here you can see it is taken in coronal view, and the second one is in sagittal view. So this is an enlarged cellular mass that is going above the cella, so it's going to the supracellular area and resting below on the cellular floor. On the either side, these two black dots are ICA, internal carotid arteries on the either side, that is encased within the cavernous sinus. So this is the cavernous sinus. This is in the sagittal view again. Okay, and if you can see a thin rim of tissue over here, this is the optic-chiasm being pushed by the tumor superiorly. This patient will definitely come with bitemporal hemianopsia. So remember Olaf from the movie Frozen? Snowman. Basically we call it a snowman sign because of the typical appearance of pituitary adenoma over the MRI pictures. Okay, so this is called as snowman sign. Next, what is pituitary apoplexy? So this is a condition in which there is hemorrhage and or necrosis within the pituitary adenoma that leads to its expansion. So the patient presents with paroxysmal headache, sometimes with vomiting as well, and acute visual loss and few endocrinological problems. This is a surgical emergency, and decompressions will be done within 7 days. Otherwise, the visual loss will not be reverted back. Till then, you have to give glucocorticoids. So you see, this is a pituitary adenoma with hemorrhage inside. So this is a pituitary apoplexy. See this line? This is one type of fluid here, and this is another type of fluid over here. So this is fluid level. This one in the middle, it's called fluid level. So what are the indications for surgical intervention in any pituitary adenomas? It's 3. If there is documented tumor growth in a patient who is being medically managed, or you are following the patient with serial MRI or CT scan, usually MRI, and you see that the tumor is growing in size in the successive MRI scans. Also, if the mass is producing any symptoms like visual or any other endocrinological symptoms, or if there is compression of optic chiasm and the patient starts to lose vision, or the patient has bitemporal hemianopsia. The surgery is done either transcranially or through endoscopic approach. Transcranially, there are 2 different approaches, pterional and subfrontal approach. Endoscopically, you will go through nose. Before surgery, you have to give stress dose of steroids, antibiotics, optimize the thyroid hormone level if there is any deficiency. You should also replace cortisol if there is deficiency of cortisol. So among the transcranial approaches, the first one is subfrontal. If you see the red dot over here, okay, you will go through the frontal bone, you will remove this bone, and also in the side view you will remove this part of the bone and you will go inside through the frontal lobe, below the frontal lobe, so it is called subfrontal, and this provides access to both the optic nerves, but may be more difficult in patients with prefixed chasm if the chasm is lying before the sella. So next one is terional approach, or also known as frontotemporal approach, commonly known as terional approach. So you will remove the frontal and temporal part on the side, usually on the side where the tumor is more inclined towards either left or right, but if it is in the middle you will go through the right side because it is the non-dominant side. So this is the portion. Now it places optic nerve and sometimes carotid artery in line of vision of tumor, and there is also incomplete access to intracellular contents. So it gives good access for tumors with significant lateral extracellular extension, either on the left or right. So this is the frontal approach, subfrontal approach. You are going inside through here and working on the pituitary gland. This is how you remove the bone. You retract the brain on this side slightly and you go below the brain towards the base of the skull. So this is the tumor, this is post-operative picture. You can see the operative steps over here. Next one is terional approach. See how the skin incision is given and frontotemporal part is exposed here. And once you retract and reach towards the pituitary, this is the pituitary gland. These are the neurovascular structures surrounding. This one is optic nerve, this one is optic chiasm. This is how you will approach through terional approach, and then you will remove this tumor. Now let's move towards the transsphenoidal approach. This is the procedure of choice these days for pituitary adenomas because this is an extra-arachnoid approach. You do not have to retract any brain and there is no external scar as you have to go through the nose. But sometimes after the removal of tumor you have to pack the area with fat graft, which we usually get from the right thigh or right side of the abdomen. So you can see scars on those areas, but there is no scar on the head. So this is usually the procedure of choice, and it is usually indicated for microadenomas, macroadenomas without significant extension laterally and beyond the confines of the sella turcica. So if the patient presents with CSF rhinorrhea and tumors with extension into sphenoid air sinus, this is a very good approach. Transsphenoidally, you can go through nose, which is known as transnasal, or you can go through sublabial area. You will go through the upper lip, but this is not really used these days, and the most popular one is transnasal. So this is how it is worked through endoscopic way. We will show you the different steps. So you see here only the nose is exposed, and usually we go through the right nostril, this one, and this is the endoscope. This is the endoscopic tower, and this is how the patient is placed on the operation table with slight elevation and the head pointing towards the side of the surgeon on the right side. So this is the endoscopic view. This is the nasal septum. This is inside the right nostril. This is the sucker. This is the middle turbinate. So you push the middle turbinate laterally and nasal septum medially, and you will try to find the sphenoid ostium, which is somewhere over here. So once you do that, once you expose the sphenoid ostium, On the either side, you remove the mucosa everywhere until you expose the vomer bone on the middle. This marks as the midline of any endonasal approach. After this, you will remove this vomer bone with high speed drill. The vomer bone has been removed here, and you have entered the sphenoid sinus. This is the sphenoid sinus, and the center line you can see over here, this structure, this is the sphenoid septum. So once you reach the sphenoid sinus, you remove the septum here, you start to drill the base of the skull now, which is the sellar floor, and this is the bony fragment remaining here. This one is the dura. Okay, you have reached the skull base. You will, after this, you will give a crisscross incision over the dura. Now the incision is being increased by cutting. Angled ring curette is being used now to remove the pituitary adenoma. So this is how it will look like. Soft, gelatinous, easily suckable. So once all of these are evacuated, you will pack this space with fat graft. You will use fascia to close the defect, and also you may put the bone from the nasal septum to cover it. Sometimes you place a flap known as Shahzad flap to cover it so that there is no CSF leakage. What could be the complications? The intraoperative complications could be injury to the carotid artery, which is a very devastating injury. Next one could be injury to the optic nerve, cavernous sinus, or nerves within the cavernous sinus. Post-operatively, you can have diabetes insipidus, surgical complications such as empty sella syndrome and hydrocephalus. The long-term complication could be sphenoid sinusitis. Thank you so much for listening. You can follow us in our official Facebook page, KEMU Neurosurgery, and if you want to see the live surgeries from our department, you can follow NS KEMU Live in Facebook. Thank you so much and have a good day.